Let us pray. Dear Lord and Heavenly Father, we thank you so much for this land, Jamaica, land we love. We thank you that we are here to discuss the matters that relate to the health of this nation, even in this time of this COVID pandemic. And so, Lord, we pray, thanking you for our chairman, we pray that you'll direct his leading and the deliberations which will happen here today. Bless us, we pray, give us wisdom, and cause us to have consensus at the end of this all. We would have said it was a good time that we would have had here today. For these and other blessings we ask in Jesus' name, amen.
Amen. Thank you very much. Okay, apologies for absence. I would like to begin. I have a list here of Dr. Angela Brown-Burke, Ms. Tova Hamilton, and Mr. Anthony Hilton. All three members have apologized for their absence. And I have one apology for lateness, Mrs. Marlene Malahou-Fort, and Ms. Juliet Holness, who is on her way.
Chairman, Senator Allen has asked me to apologize for absence.
So Senator Allen also absent. Okay, anybody else? No? All right, so let me just quickly add my opening and welcome remarks. First of all, welcome to the team from the Ministry of Health and Wellness, quite an expanded team this afternoon. I appreciate your presence, and what it means for committee members is that we have quite a lot of capacity to deal with the circumstances at hand, and there are a few as it relates to COVID. So I perhaps should ask them to quickly identify themselves. Some are very obvious, but others may not be so. So maybe, Dr. Williams, you want to just begin? Just state name and your title, just for context. And
I'm Nadine Williams, the Director of Health Services Planning and Integration at the Ministry of Health and Wellness.
Great.
Good afternoon. I'm Judith Leiber, Director of Child and Adolescent Mental Health.
Okay.
Dr. Bisesa McKenzie, Chief Medical Officer.
Dunstan Bryan, Permanent Secretary.
Melody Ennis, Director of Family Health Services at the Ministry of Health and Wellness.
Michelle Hamilton, Director, National Laboratory Services.
Afternoon, everyone. Nicole Dawkins-Wright, Director for Emergency Disaster Management and Special Services Branch at the Ministry of Health and Wellness.
I didn't hear anything you said, Dr. Dawkins-Wright. Can you say it again and slowly, because we're taking notes, and I didn't hear. Go again.
Nicole Dawkins-Wright, Director for the Emergency Disaster Management and Special Services Branch at the Ministry of Health and Wellness.
Disaster Management and Special Services Branch. Okay.
Ayana Wellington, Medical Epidemiologist, Communicable Diseases, Ministry of Health and Wellness.
Okay, great. Thank you again, team. I know you're stretched, so really appreciate making the time this afternoon. Just again, in welcome to the members. Obviously, we are few in numbers, but nevertheless, the matter is important. We have two members that are on their way, and we will begin until that they arrive. We're also, of course, these proceedings are not just recorded, but televised. So whatever we say here is not just for our purposes or for problem solving, but it's also for public education, consumption, education, and hopefully understanding. So don't just watch the numbers, because we're also in the virtual stratosphere, which is a good thing in the interest of transparency. There is a lot to go through, so I will go straight into the minutes and confirmation in matters arising. and then we go into the presentations. For presentations, we have the regular update on COVID-19, update on vaccines, and then we have a request that was made. We will deal with a presentation on mental health and as it relates to COVID, and Dr. Leiber is here who will help us with that. And I'm going to recommend that we allow the presentations, jot down the questions, and then we have a discussion after the presentations, if members agree with that. All right, can we just go quickly now through the minutes there before us? Page 1. Everybody has a copy? The members have a copy? Yeah? You have a copy of the minutes? Minutes. You have a copy? Yeah, okay. So page 1. Page 2. Page 3. Page 4. Page 5. Page 6. Page 7. Page 8. 9. 10. 11. Okay, all right. Okay, so if there are no corrections, can I ask that the minutes be confirmed? Move, member. Seconded. Okay. Matters arising, and in our usual way, if you think your matter will be addressed in the substantial presentation, then we could await those presentations. Are there any matters?
Just one, Chairman. I have some, but I'll await as the usual protocol was suggested. You know, Minister, we had our discussions last week in the Parliament, which I gather were based on the House Leader's presentation done ready for the previous week. I want to know, based on that, and having regard to the fact that it falls in the minutes, the question about ivermectin was asked, whether there's any new update since your last advisory from your technocrats that you presented in the Parliament and now, in terms of the usage, and whether there has been any developments.
Okay, so the clinicians, maybe the CMO can comment on if there's any additional information since the presentation. I can comment on the efforts of at least one private sector entity that is attempting to import the drug. Indeed, I had a discussion with one of the senior managers, principals of that entity, and the Standards and Regulations Department around information required to import the drug. And the company in question committed to following up based on some missing information. And it wasn't, I think it was an important discussion because clarity was brought to the table in terms of what was in fact needed and what was missing. And I think there was some understanding and appreciation of what needed to be had. So the company indicated that they would continue the efforts to get the information, and we committed to turning around the application in a short period of time once they provided that information, which is standard information, nothing different from what is required for any drug. So that probably would be considered an update in terms of some progress being made. As it relates to the science and the research and the study around ivermectin, I would have to yield now to maybe the CMO to see if there's any new development outside of what was presented in Parliament. CMO?
Good afternoon, everyone. Well, there is no new recommendation, although we do recognize that a study is going to be done in the UK by Oxford University that would promises to give good outcome results, and we look forward to seeing the results of that to see if there is enough supporting evidence to recommend ivermectin as a method of treatment.
Are you therefore saying, CMO, that if the studies come out of Oxford University in the UK are very promising and clearly indicate that there is some usefulness in ivermectin in treating COVID-19 infections, even without WHO approval, that would be part of the consideration for Jamaica?
We certainly would depend on because this is not the only study. I mean, since recently we've seen that there's a lot of randomized control studies that are being done. However, there is still considerable variation in dosages, in patient selection, in the outcome points. So certainly this study coming from Oxford would add to the body of information that there is and will contribute to the knowledge. Jamaica is really not in a position to widely dissect these studies and look at it, but I am certain that all the bodies, including the WHO and the other regulatory authorities, would look at this study and are expecting that, that it will add to the evidence for or against.
Bear in mind, member, if I may, that we did say, well, I said in Parliament when I responded to the questions that you posed, that as information or more information became available, we would be, the clinicians, the experts would be willing to review and could adjust the decisions, the decision around ivermectin. And I think that applies to the science generally, and so it's a reasonable expectation. Okay, any other question? No? All right, so can we then go into the update? Is it yourself, CMO, who will do the initial update? All right.
Dr. Wellington will give the epidemiological update, sir.
Okay, Dr. Wellington. Hello. Yeah.
Okay, so as at yesterday evening, this is what the picture looked like for COVID-19 in Jamaica. And this is the number of cumulative cases since the start of the pandemic. So that's what that map shows. Sorry, it's dark, right? Okay, so the one in the red is 47668. St. Catherine is 9856, and KSA is 13776. Okay, so as at yesterday evening, we had a total of 49,795 confirmed cases of COVID-19, of which 958 were imported and 48,837 were locally acquired. We've had a total of 1,042 deaths with a case fatality rate of 2.1%. The rate of deaths per population stands at 38.6, and if we exclude the imported cases, it's 38.3 per 100,000. The daily positivity for June 22nd was 7.8%, and the 7-day average positivity stands at 6.7%. We have been hovering around 7 to 8% for some time. And the table shows the distribution of cases, cumulative and newly confirmed cases. The age distribution is shown here, and this pattern has held for some time, with the persons who are in the 20 to 29-year age band having that age band has had the largest number of confirmed cases. As far as the age distribution of the deaths is concerned, of note, the case fatality rate and the proportion of deaths is highest in persons over 60 years of age.
Dr. Wellington, could you go back to the previous slide in terms of age distribution and the cases?
Of cases or deaths?
Cases.
The sex distribution shows more female confirmed cases and male confirmed cases, with 56% females and 44% males to date. As far as comorbidities are concerned, consistently we have had, and risk factors, we have noted that of the deaths, age is one of the risk factors for death based on the data that we have. And cardiovascular disease is also, and diabetes are also risk factors. As far as the sex distribution of deaths is concerned, this pattern has also held over time, where we've had where the case fatality rate for males has been higher than for females. These maps show the numbers, the absolute numbers, so similar to the first map I showed is the one on the left, with the absolute number of cases at the top and the active cases at the bottom. The rates are also shown overall cumulatively per 100,000 population at the top, and the rate of cases per population at the active cases per population at the bottom. So the parishes with the highest rate of active cases are St. Anne, Hanover, and Westmoreland in that order, descending order. As far as the deaths are concerned, the total rate of deaths per population, KSA overall for 2020 and 2021 has had the highest absolute number of deaths, followed by St. Catherine, followed by St. James. And to date, for 2021, KSA has had the highest number of deaths, followed by St. James, followed by St. Catherine. And this is the death rate by parish. So this is overall for the pandemic so far. Trelawney has had the highest death rate, followed by St. James, followed by Westmoreland, and this is by per population. As far as geographical spread is concerned, we've noted that 30.5% of communities, statin communities, have had COVID-19 cases diagnosed within the past 2 weeks. And this curve also shows the trend. This curve shows a trend in the proportion of communities that have had active cases at any given point in time. So it's similar to the first, conveying similar information. At present, we have this map shows the geographical spread of COVID-19 and shows the parishes in green with lower spread, lower spread, and the parishes in amber or orange having the highest rate of spread. So this is an epidemic curve that also shows the number of the number of hospital admissions by the dates on which they were admitted. These are the parish epidemic curves showing the number of cases by date on which the person started having symptoms by parish. This one shows the number of this is another epidemic curve, but it's showing the number of cases by week of onset, as well as the number of deaths by week of death, and also bed occupancy and the weekly positivity rate. So everything here is by week. As far as the comparison, so this shows the number of cases, COVID-19 cases. So it's an epidemic curve, but it's also looking at the number of available COVID-19 beds, which is shown using the line on the curve. Okay.
Excuse me, could you just go back to that slide, please?
The gray and...
The beds. So this is available COVID-19 beds now?
Yes.
Or is it capacity?
Sorry, capacity.
Okay.
Which has changed over time. This is an explanation of what the different levels of pressure on the system. So what the red, yellow, amber, green mean. The positivity has gone down over the past few weeks. This curve shows the daily positivity as well as the 7-day average. The daily positivity rate as well as the 7-day average, which I had spoken to before. And this one shows the number of the positivity rate by when the test was actually done. Right, this is another curve showing bed occupancy levels. This speaks to the reproductive rate. So the reproductive rate, when we look at the confirmed cases, stands at 0.7, and when we look at the admissions, stands at 0.9. And this is what how the reproductive rate has changed over time. This is an explanation of what the positivity rate, which I had mentioned before. So we look at the number of positives. It's a percentage that is calculated using the number of positive COVID-19 tests over the total number of COVID-19 tests that were done. And again, speaking to the trends in positivity, I had mentioned that the daily positivity stood at 7.8%, and the 7-day average is 6.7%. Okay, and just to summarize the different indicators, the bed occupancy stood at 30.5%. Sorry, the geographical spread was at 30.5%. And you can see the bed occupancy there, as well as the 7-day average positivity stands at 6.7%. Reproductive rate is under 1 at this time. And vaccination levels remain fairly low in terms of their expected effect on transmission. Thank you.
All right, I'd ask what members prefer. Do we prefer to spend a little time on each presentation? We have 3, or you want to do all 3 and then ask the questions? I mean, I'm going to allow you to ask, but I'm just wondering which you prefer. Obviously, I'd have to control the time, so I would allow.
I would have preferred after each, but in light of the exigencies we have, Chairman, as was agreed sometime before, we'll wait until after the presentation.
You want to? I'm going to allow you a burning one since you're already on the floor.
Okay, thanks. It's just that I want her to go back to this slide table titled The Situation. I think it's like the second slide or something. Thank you, Mr. Chairman. Well, Mr. Chairman, while she searches for that slide, with your permission, I just want to also express my own thanks to the team from the ministry. Some days when I open social media and I see the licks and the cussing, I just want to hug each of you, and I'm not even a hugger. But so thank you so much for all the work you're doing and all the licks you're taking. Jamaica is, ignore the noise and just know that we appreciate it all. All right, yes, St. Anne. Why is it so much of an outlier? Based on the numbers there, it seems like an outlier. Do we have a reason for that? Nowhere else is in the double digits. Or am I reading, in terms of new? Am I reading it wrong? I'm not good with graphs or tables.
Okay, so this is a number of new cases for a single day. So it fluctuates from day to day.
So there's no trend happening in St. Anne? It's just that one day happened to be such an outlier?
I would say that, yes.
Okay, thank you.
Actually, I had the same, but it's not from this slide. The one that had the map of Jamaica with the medium, high, and low spread rate, I think it was. And I think it is St. Anne that also kind of stood out too. So I myself wondered about it, and I just kind of said St. Anne is, I think, is our largest parish, and I just thought it was probably based on the numbers. No, well, because densely populated. So St. Catherine was in high. So you had St. Anne was surrounded by low spread, and it had medium. Whereas King Casey and such, the map with the Jamaica map and the...
Before you go, Chairman, there was just a small follow-up to the first question before you get to Dr. Longmore's question, if you may.
Anyways, but I just think it might be related to the population size there. I don't know if there was a particular outbreak of some sort or something. But I too wondered about it. It's not that one. It's not that one. It's one single map of Jamaica, and earlier than this.
Look at this.
No, let's just go back to this to explain.
It's okay. I mean, we can process it later on.
Right. No, but just to show you that this is the epidemiological curve for each parish.
Mm-hmm.
So you can see St. Anne.
I can't see which one is St. Anne.
St. Anne is in the upper right corner.
Okay.
Right. So we're not really seeing that there is a rise in cases in any parish, generally speaking, no.
Right.
The general trend is that it is trending down. But we do note that there are some parishes that we have been noticing that there is the on and off increase in the number of cases. And those parishes are in particular outside of St. Catherine and Kingston and St. Andrew that are our largest population, so you're going to see high numbers.
Mm-hmm.
You will notice periodically that St. James, St. Anne, Trelawney and Hanover, and Westmoreland occasionally, those parishes on the northwestern side of the island tend to be parishes that when Ayana had gone through and you saw the overall cases, confirmed cases cumulatively, both for deaths and for confirmed cases, you would have seen that those parishes featured.
That was my, because out west we're all within the particular medium range, whereas St. Anne was the only one in the middle parishes that stood out. So I just wondered, whereas Casey and such was high. So I just wondered what happened in St. Anne myself.
Member, you want to ask yours, and then we complete the quota.
Just a quick question. Thank you. The matter of antigen testing. I see St. Anne is the only parish in that listing which there's antigen testing done. Is there any particular explanation for that? And why aren't the other parishes doing antigen testing, Yes, and St. James.
There other parishes are doing, but we are just reporting what came in on that particular day. So on the day in question here, I think we had results that came in from St. Anne. We have a cutoff point in the morning to report the results for that day. So all of the parishes, most of the parishes are able to do antigen testing, but on this particular day, where are we? I'm trying to see. Yeah, on this particular day, results would have come in from St. Anne, but it's not the only parish. If I'm looking at this, I'm seeing here St. James would have sent in some, and St. Anne, and I think those are the only two on that particular day. But on other days, we have coming in from Manchester. We have antigen testing established at all of the regional hospitals, and some of our larger hospitals. So, for example, in the regions, we have it at Cornwall Regional, we have it at St. Anne's Bay, and which other region? And we have it at St. Anne's Bay, Cornwall Regional, Mandeville, right. And in Sarah, we have it at large hospitals such as KPH, and Jubilee is next door, so Jubilee feeds KPH. We have it at Bustamante. We have it at Spanish Town Hospital. So we have our larger hospitals all have the antigen testing, and the regional hospitals have it. So what happens is that the hospitals within the region, they are able to feed their samples to the regional hospital for testing, or they can send the samples directly to Kingston for testing if, based on where they are located, it's easier to get to Kingston. For example, if we think about the way NERA is set up, we know that we have, it's a wide parish, it's a wide distribution. So to send samples from Onoto Bay all the way to St. Anne's Bay, you can see it would be easier to just send them to Kingston. So depending on where the parish is located, they may not send to the regional hospital for testing. They may simply send direct to Kingston.
But if I may, Dr. Hamilton, I hear and understand what you're saying. The reality, however, is that if you check the report of the summary for each day that is put out by the Ministry of Health and Wellness, there's very few days that the numbers exceed, in terms of antigen testing from the public sector, exceed 20. It is always, and in most cases, it is below 10. And if you flip back for the past month or two, you will see 3, 7, 3, 4, 3, 14, 9, 11, 23, 6, and numbers like those. The point I'm making is that there is less usage of the antigen testing out there in the locals.
Right. To respond to that, Dr. Guy, you're going to find that because now we have almost a 24-hour turnaround time for tests. You're going to find that a lot of antigen testing is not done in the public hospitals because it's easy for them to send them for PCR testing and get back the results in a timely manner. And so that is why we don't tend to have a lot of usage there.
But even for the Western parishes?
Pardon?
Even for the Western parishes?
Yes, even for the Western parishes, because they're taking samples almost every single day. So.
And if I may say too, that what we are reporting for the public sector, the algorithm that we are using, if you have a symptomatic patient and the patient is negative, then the sample has to go for PCR testing. So what we are reporting on the antigen testing for the public is really just the ones that were confirmed positive initially. All the others, the negative samples for the symptomatic patients, are sent for PCR testing, and so their final result is reported on the PCR testing. So when you see the total recorded for antigen tests in the public sector, it's really just looking at the total positives that were recorded by the public sector for antigen testing, not the total number of antigen tests that were done in the public sector on that particular day.
No, Dr. Hamilton, I beg to differ. Say for the 10th of the 6th, 2021, there were 1,481 tests done, which is a combination of those that were done in the public sector, which is 730, which is antigen, 6 in the private sector, 730 antigen, 6 in the public sector antigen, and 745 in the public sector, which is PCR, and you get 69 of those.
Yes, what we are saying is this. The figures recorded under the public sector only records the actual positives that were obtained for that day, not the total number of antigens. The total number of antigen tests, the ones that are negative, are sent for confirmatory PCR testing. And so the report that we give out is the report of the PCR test. We do not specify how many of those PCR tests were first tested by antigen. We just give you a final figure for the PCR testing. So it may seem as if we are not doing the antigen tests in the public sector, when in fact we are doing a lot more than is captured in the release, but the remaining samples are being reported under the PCR test result because that is the final confirmatory result.
Okay, thank you very much, members, and we're going to go back to the original agreement with the other two presentations. But before that, I want to welcome Member Holness. Thank you very much for coming. And I am going to ask that a motion be moved and seconded to adopt or formalize this session leading up to this point and for the rest of the meeting to be logged. Moved by Member Guy, seconded by Member, both of them moved it, both seconded, so who would you assign it to? Okay, all right, so thank you, that's good. So can we move to the next presentation now? Who is going to be doing that? That's on the vaccine update. I think Dr. Ennis? Oh, you, PS?
Yes.
Okay, so we're gonna look at vaccines.
So good afternoon, Chairman, members of the committee. Today, we will be looking at our vaccination program and the implementation of the vaccination program to date. Strategically, members, the Government of Jamaica, through the Ministry of Health and Wellness, has targeted our population over 50 years based on our risk analysis for negative outcome for COVID-19. And as can be seen by the graph presented, that strategy has seen the majority of our vaccination being done in the age groups that we are targeting. And so we continue to leverage our existing supply in terms of vaccination of that particular target group. In absolute numbers, the number of persons vaccinated are from the Kingston and St. Andrew parishes. And we continue to see that when we look at our rates in terms of percentage, Kingston and St. Andrew represents the largest proportion of population that has been vaccinated. We had our Blitz exercise over the weekend, and in that exercise we vaccinated approximately 16,000 persons in total, and the larger sites carried the lion's share of the numbers. 10 sites in particular carried the number of vaccines that were distributed over the periods 19 and 20, which is Saturday and Sunday, while we rolled out the Blitz operation. So overall, I can't see that. So overall, currently, approximately 9% of the Jamaican population has received at least one dose of the COVID-19 vaccine. Our current vaccine distribution is around AstraZeneca, which is a 2-dose application. The total number of persons who have received one dose only is about 6.3%, while 2.7% have received both doses of the vaccine. In terms of our vaccine supply projections, we see from the presentation before you that we have different suppliers that we have received from and are projected to receive.
Yes. Is that the population or the targeted group? In terms of the 6.3% and the 2.7% that you mentioned earlier. Is it the
population?
Population.
Population. So for our COVAX, we have received 14,400 to date, 55,000 in April, and another 55,000 in May. In July, we are projected to receive through our COVAX supplier an additional 66,000, but this 66,000 projection is not final. It is still in negotiation based on the fluctuations in the market for vaccines and depending on what is happening in the international movement of vaccines across the world. So right now, our best information at this time from COVAX is that we should have a supply in July of approximately 66,000 AstraZeneca vaccines. We note our donation from India. We also note our donation from South Africa. Now we have, and we can report that we have finalized the supply agreement with the African Medical Supply Platform for approximately 1.9 million doses of Johnson & Johnson vaccines. And based on our most recent conversation with the African Medical Supply Platform, our first supply of vaccines should be in August. And we note that it is also in red because, again, based on the market and the fluctuations in market, our projections of approximately 15% of our total allocation of 1.9 million doses is to arrive in August. However, again, these are not final arrangements as we work through the very turbulent supply market for vaccines. We have confirmation for a donation from the government of Mexico for 35,000 doses of AstraZeneca. And those 35,000 doses are to arrive shortly in Ireland to specifically deal with the second dose application of AstraZeneca to the population that have already received their first dose. And so we expect that this delivery will arrive in Ireland between now and the end of June. Our latest conversation as well with the United States government, the government of the United States of America, is that we will receive a donation of Pfizer vaccines. However, we are unable, and at this point in time, to announce any specificity around number and date of arrival. We are still, based on the conversations that we are having with the government of the United States, and that conversation is being led by CARICOM in collaboration with the Caribbean Public Health Authority, CARFA, having this conversation, and it is projected that this donation, once finalized in terms of numbers and volumes, will be delivered by the end of June. That's our latest information. Again, there's a level of uncertainty that surrounds this particular donation. So that's our best information at this time, and that's the extent of the presentation on vaccination.
Can I just add to that before the next presentation, and then we go into questions? The issues around vaccines, we know, is quite current and topical and has raised a lot of anxieties among the population or sections of the population, particularly those persons who have had their first dose and have dates for second dose, which are now being reached, and we have asked them to be patient and to hold on. I just want to say that the government, certainly the ministry, myself as minister, fully appreciates the potential for those anxieties and fully share an understanding with those persons who are anxious to get their second dose, to complete the dosage. In fact, we think it is a good indication of the willingness to take vaccines, to take up, and it is critical because hesitancy is a major hindrance. So I really am heartened to see persons really being very vocal about the need for themselves to get their vaccines, themselves or family members. We had anticipated that we'd have gotten to a point where we would have some slowing down of availability, and we have said it. Maybe we didn't say it enough. Communication is important in these things. Some persons ask why it is that we didn't plan better to have the second dose in storage for those who had the first, rather than to deliver all that we had or most of what we have for first and now running into difficulties for the second. Those are legitimate questions, and so I don't resile from them, and I think we need to provide information, and better and more frequent and consistent information to address those issues. A couple of things I want to say that we have said, but I think it's important to repeat. Firstly, I certainly regret the inconvenience that has been caused with the rush on some of the locations, particularly the National Arena, and today we have seen where the Mona Aging Center had a rush, which really meant no vaccines were delivered. And so those who have been inconvenienced, particularly our senior citizens, it is not a desired position, and it's indeed a regrettable position on the part of those who have had to suffer the wait without successfully getting the vaccines. We have to strive to do better, and we will, but a few important issues. One, the vaccines and the efficacy of the vaccine allow for a period of time, up to 12 weeks, according to the clinicians, the experts, from the time of the first dose. And the persons who may have due dates in their cards are no one in our database, as far as I know, have yet reached a 12-week period without a vaccine. Am I correct? If that is the case, then we would have to determine who those people are, but that's not my information. The persons who are coming close to achieving that 12-week period are going to be given priority. And the information going out to persons to come in are in fact those persons based on the information we have, the database. So we ask those persons, once you're contacted, to come out. We say to others who are anxious, and understandably so, don't come if you're not contacted, or if you feel you're close to that date of the 12-week period, make contact, because it is possible that we could overlook or the system may not fully account for everyone. You can go to your health center, you can call the 888 number, you can go on the website. If you think your date of that 12-week is coming up and you haven't been contacted. But for the overwhelming majority of those persons, as far as I know, we prioritize based on the persons going close to that date. The second thing I'd say is that the issue is not so much a lack of planning as it has been impacted by the lack of availability of vaccines and the unpredictableness of the expected supplies that we were hoping to have. I had given a statement in Parliament in the early days around the COVAX facility and the amount that should have been delivered. The fact is we have gotten a fraction of what we were committed, was committed to us. And that was in writing, commitments in writing, not just a verbal commitment. So the erraticness in the marketplace for the supply of vaccines have made it very difficult to plan. The other element that would have impacted the second dose availability would be the fact that we had gotten the 75,000 doses of vaccines that would have expired in 5 or so days, and we did the blitz and successfully delivered those vaccines, and therefore we would need to have additional supplies to give the second dose. And so logistically, we in a sense were forced to deliver what we had, and then almost get the second tranche to make the second dose possible. And because of the unpredictableness of the market, we have been placed in this very uncertain position. So for those circumstances, we have seen the uncertainty, and the uncertainty creates fear, and the fear creates the panic that leads to the rush on the locations. We do believe, however, that in the coming week and weeks, we will have the supplies to begin to alleviate that uncertainty. So the 35,000 coming out of Mexico, all other things being equal, we should have here in a relatively short period of time that will be committed to second dosers and those who are closest to the 12-week period. There's another small allocation that we will get, or we expect to get this weekend into Monday. And then the discussions as outlined with the PS with COVAX, we're hoping that that will further alleviate the problem. So while I agree that there are issues, there are challenges, while I accept that we perhaps can communicate more effectively to create the understanding and maybe apply some better customer service response at some of the locations, particularly larger ones, I want to also say that there are variables in the planning of this process that are outside of our control, unfortunately, vaccine availability being a key one. And it really makes the situation very, very difficult. So I want to just appeal to the public and ask for their understanding. And to say, too, that the public health team in the field are really doing the best they can. They're very tired. They've been at this for a long time and fatigued. And they are as frustrated in not being able to deliver the vaccines as we all are. And so, we ask them, the public, to understand and, facilitate with some patience the process until we can get to the point where we're at. I thought it was necessary to add that because up to today, I've seen a lot of discussions in the social media space, in the mainstream media, of persons really irate around the availability of their second dose. And I think it's important that we recognize their frustration, express regret, and commit to ensuring that the process works for them and ask them for their patience.
Chair, I just wanted to also, because communication is key, to alleviate the anxiety around the 3 months, the 12-week, that is actually shown that the efficacy might actually be better with the delayed 3 months rather than the 6 weeks. So it is also, I think a lot of persons are concerned about the fact that they're not getting it. They might get it delayed, it's not going to work. We need to let persons recognize that if they're in no danger, they might actually get an enhanced protection at the 12-week mark, and what is critical is that they reach out as they're approaching that 12-week mark for us to get to them.
Thank you. All right. I know you may have other questions on vaccines, but I'm going to ask Dr. Leiber to just make her presentation, and then we can come back to this. That's not your presentation, though.
No. Okay. Okay, good afternoon again. I'm going to present on the COVID-19 mental health response. Generally speaking, our mental health response was geared towards the risk, the level of risk that different sectors of our population would have posed. For instance, in the general population, what was the problem was a lot of uncertainty and fear, as the esteemed member mentioned. And so therefore, public education, public service announcements, and flyers were distributed, what we call IEC materials, information, education, and communication materials. The next group that also exhibited some risk were the persons who were in quarantine and isolation, because initially they had to go into national facilities to be quarantined or isolated into hospital, and also they were at that time, the length of quarantine and isolation was much longer because it was test-based. So that created a lot of anxiety among the persons in this position as well as their relatives. At that time, what we were able to do, well, each person who went into this facility got a brochure about taking care of your emotional health. And we also were able to, through the counselors in the helpline, initially, when numbers were small, we would give the counselors the numbers if the person had a phone number and was willing to be contacted. And the counselors would actually make contact with them and find out how they were doing. And conversely, we also told them that they could call the counselors whenever they wanted. For those in our mental health clinics, the adults and the children, well, I think I'll mention that when we go. But we had to make some special arrangements for them. Healthcare workers was a particular group that had their own special needs. And I don't know if you can read it, but in the Northeast region, what the regional psychologist did was that she was able to garner help from the Jamaica Psychological Society. They formed WhatsApp groups. Each group comprised the workers on a certain ward, and through those groupings, they were able to communicate psychoeducation, peer support, and offer peer support and also just regular psycho support. I'm sure you'll remember that group, the youth, the cluster from the BPO. And here we had a group of young people in isolation, feeling perfectly well. And again, they were probably looking forward to, let's say, a month in isolation. So again, we had to figure out how are we going to keep them busy, gainfully, and out of trouble. And the other groups there as well. Okay, so mental health and psychosocial support is a framework that is utilized a lot when you have disasters and emergencies. So you'll hear it mentioned, like how the hurricane season is now upon us. This is something that we have to kind of rev up, so to speak. And one of the pillars of MHPSS is psychological first aid, which we teach to lay people. And the 3 action principles of psychological first aid are look, so you really approach somebody who may be in distress, you listen to them, you assess what he or she may need, and then you link them with whatever help they may require. Very simple. We're not training them to be mental health workers or anything like that. It's just basically being considerate and helping folks. I'm not sure if you can read this, but this epitomizes our pyramid of intervention in mental health and psychosocial support. So at the base, you have self-care, and that's one thing that we had to preach to everyone, because everybody had to take advantage, pay attention to their personal mental health and how they were taking care of themselves physically as well. PFA, psychological first aid, was employed by the foot soldiers, like Red Cross volunteers. And they were persons, general population, could also call the helpline if they needed help. So that would have been available to most of the population. Going to the middle part now of the pyramid are persons for whom the initial slate of interventions would not have been enough. They were still anxious, they were still depressed, and therefore they would be seen by maybe this, not be seen, be contacted by the psychologist or other mental health care workers. And then at the top we have psychiatrists who would then see them if they needed that amount of intervention. We had to prepare our own mental health staff first. So we had to look about their well-being, and we had to upgrade their training, particularly in infection prevention and control. And also we had to give them a refresher training in mental health and psychosocial support so that they could go and kind of be leaders and trainers in their own area with regard to psychological first aid and MHPSS. And we utilized a protocol for maintaining service in a pandemic. So we did like an outpatient docket review. The patients who were able to get longer appointments, because the whole point was to really minimize face-to-face interaction between patient and practitioner. So those who could get longer appointments were given longer appointments. Where it was appropriate for those persons to get prescriptions beyond a month, NHF was mandated to actually dispense up to 3 months. And sorry. Okay. And we had to develop protocols as well for our crisis team to interact with, let's say, a person who was out of control. And I'll just say here that a mental health nurse, this is a notable quote, a mental health nurse says that in apprehending or restraining a person who is out of control is like a wrestling match. So you can imagine the exchange of aerosol droplets and body fluids. So we were very meticulous, the mental health team, about calling our patients who were high risk, make sure that they had their injection. Our home visits went up, and also if there was any sign of decompensation, we would know and intervene early. Okay. Just reiterating here that the mental health needs of those in quarantine and isolation changed when we changed our protocols, as science dictated. So when the isolation and quarantine period was was changed from mandatory national to being a mandatory national facility to being at home, we had less mental health calls. And when we changed our discharge protocol from a test-based method to a time-based method, 14 days, the mental distress in those affected also declined. Improved. Okay. Helplines and destigmatization. These two initiatives actually started before COVID. And I must pay tribute to our Honorable Minister for his support in in getting some of these initiatives off the ground. The destigmatization campaign was very useful because those who were affected or infected by COVID, they faced a lot of stigma from their community and sometimes from their own family members, and even our healthcare workers were facing stigma from the community if it was known that they were working with COVID patients. And the helpline was extremely useful because, again, we wanted to minimize face-to-face interaction. So our helpline, which actually started before COVID, October 2019, came in very useful, as I said, for instance, to contact persons who were in quarantine, isolation, and anybody could contact us. 188-NEW-LIFE, it's available 24/7. There was also a proliferation of helplines, as shown here, because I guess different sectors wanted to offer help and support to the population. These posters were part of our destigmatization campaign, widely publicized. I remember the red one being in the Sunday Gleaner at least 3 weeks in a row. The Sunday Gleaner has a circulation of about 50,000. So it was very wide, they were widely publicized. And then this is just a pictorial representation of the number of calls to the helpline. These are the totals. And if you can remember the graphs from Dr. Wellington, it almost seems to mirror that, the graphs in terms of the spikes. So that would be the total. And then the female, that's the number of female callers, and then the number of male callers. And just as an aside, usually, roughly, the number of female callers is twice the number of male callers, which is not surprising, of course. And then we come on to the training component of mental health and psychosocial support. And I've put Zoom, because we all had a lot of Zoom meetings, and all the trainings that were done in the different sectors had a mental health component, and we also gave training to, let's say, non-health frontline workers in psychological first aid. All our healthcare workers, different categories, were having their own meetings. The staff of infirmaries, quarantine, and isolation facilities, convened their own meetings, and also ministries, departments, agencies, and the private sector. We've had numerous invitations to come and speak about coping in COVID, dealing with grief and loss, and similar topics. This is a picture of the first brochure that we developed on taking care of your emotional health. And recently, we've had to develop another one, which now includes aspect of taking the vaccine and quelling any anxiety that may arise for those who may be vaccine hesitant. A positive thing that came out out of the pandemic was that we now have the makings of a National Mental Health and Psychosocial Support Technical Working Group. We have all of these ministries and agencies represented. PAHO is assisting us with the process. So we hope that in the future, with any more disasters or emergencies, we'll be much better organized to really offer mental health and psychosocial support. And then this is an example of Reach Out Rangers. If you remember that bottom slot with psychological first aid training, where your common layperson can be trained with psychological first aid and could in turn go and help other persons in the community. So there was a launch and there was a call for volunteers. We received 117 volunteers, and they've kind of gone through a vetting process and they're ready now to be deployed. They'll initially contact folks who are in isolation and quarantine virtually, and then if necessary, they will go and see them face-to-face or try to get help for them. Maintaining services was another big area. Again, we're trying to minimize face-to-face. We employed what we call telemedicine, telecounseling, telemental health, and this initiated in the child guidance clinics, where in a collaborative effort with UNICEF, Ministry of Education, and ourselves, we were given 50 mobile phones given to the mental health teams in all regions, particularly to the practitioners who worked in the child guidance or child and adolescent mental health services. And some of our practitioners work both in the adult service and the child service, so it redounded to the benefit of also the adult service. One, for them to contact patients. Two, to be able to contact like sister agencies and to also accept referrals from our sister agencies. And that was very useful. It was the subject of a piece of research done by Dr. Shetty et al., which showed that it decreased the amount of persons who failed their appointments. That was a good thing. What am I doing? Okay. I seem to have missed out. Okay, so we had, just to touch on interventions for special groups, I told you about the cluster from the BPO. So adolescent health, which oversees the Teen Hub, in conjunction with child and adolescent mental health, we devised a program to really keep these youngsters, as I say, gainfully employed. So there was like a healthy lifestyle training in the afternoon, and in the morning they were able to be enrolled in a customer service training 5 days per week for 4 weeks, and if they successfully completed it, then they could actually be certified. Another group which we had to think about was our elderly, and we joined up, well, our health promotion and prevention branch had a program for the elderly on October the 1st, International Day of the Older Person. And it was by Zoom, it was on YouTube, and placed on our website for future viewing, and explored those topics as stated there. And the bookmarks were also were particularly given out to the elderly persons. Another group that we had to consider were those who were abusing substances. And what occurred is that because more people were at home, you would have like old mothers or aunts, concerned older persons who saw how much their son or nephew was consuming in terms of alcohol or ganja, And they would call the helpline and ask if they could get help for them. So the number of calls actually went up from 61 in the 2019 to 300 and odd in 2020. I think one thing that the pandemic has shown us is that we need staff welfare programs to keep our staff well, and then employee assistance programs for when they may be in need. And again, I must pay tribute to the Ministry of Health and Wellness, our PS, in that we now have a wellness coordinator who has devised all of these different staff wellness initiatives that people can take advantage of. And well, some of the regions have an EAP. Unfortunately, I don't think the government of Jamaica in general has an EAP, and that has always been a deficiency. I'm sure most of you are familiar with the Capri study of children and families, where they were able to show the different emotions that most of the children were experiencing. I think that is certainly online. And I also want to mention what I call the collateral damage. From the beginning of the pandemic, one could have predicted that possibly child abuse incidents would have gone up because you are locked down, so to speak, in an environment where you're more than likely your abuser is also. The child abuse reports went down, but we feel that was because the gatekeepers, like teachers and guidance counselors, didn't have access to the children to then report the abuse. Anecdotally, 1 or 2 doctors spoke about seeing an increase in child abuse, and I would predict also that this year or the following year we'll see the numbers, going up rather sharply. Mrs. Gage Gray from CPFSA was recently spoke about teenage pregnancy being up, and again, that is not surprising. We have our teenagers at home. They may not have access to commodities and may not be gainfully employed. Domestic violence, what can I say about that? Almost every week we hear about some unfortunate incident, and we think that may have gone up. Our suicide numbers went down, though, and again, the explanation for that could be that everybody was, in a small space, so any kind of attempt could have been foiled. So therefore, our actual completed suicide numbers are down. Okay, the impact of COVID on our child and adolescent mental health workload for the children, for the clinics, for the children and adolescents, it actually went down in 2020. And the main reason for that is that a lot of our referrals come from schools and other agencies. And of course, the schools were not open. So the numbers of visits actually went down. Sorry? Okay. Interestingly enough, the number of visits in the adult clinics actually went up. And I alluded to the reason earlier. There were more home visits to make sure that patients did not relapse. And as soon as patients were relapsing, our crisis team teams were on the ball to go and get them their treatment so that we would not have a lot of persons relapsing. And I gave it the analogy, we didn't want any wrestling matches around the place. So in conclusion, the mental health impact is a significant outcome of our COVID-19 pandemic. In fact, some authors have said it's going to be the next pandemic. With limited resources, we had to try to be innovative and to be very collaborative with different stakeholders so that we could mount appropriate responses. And from what I've cited before, although it has been a challenge, it has also created a lot of opportunities. Thank you.
Thank you very much, Dr. Leiber. A very fairly comprehensive presentation lots to chew on and to try to understand. Okay, well, we've had two reports all three. We did comment a little on the first one. And so what I will do is to engage the process now with questions on any of those. Just to comment on Dr. Leiber quickly though, the mental health as a side effect of COVID, you have really concluded is real. And we've seen that.
Yes.
And I think we really attempted as a ministry to reach out and to provide an opportunity for persons who are suffering to respond, certainly in terms of the toll-free line, the reach-out rangers in the community who are trained and deployed. The problem, however, the challenge has been, I think, fairly significant, particularly among all age cohorts, but certainly among the young and among the old. Yeah. The young because the kids were not able to go out to school, and so their lifestyle had to be radically adjusted, and a combination of being alone at home, maybe excessive exposure to the internet or the machines that they use to keep their company, which in itself can trigger certain types of effects. You know, they play these, aggressive games, for example. And we have certainly seen cases of that kind of challenge. And among the older population, when you speak to the Mona Aging Center, for example, Professor Eldemar Shearer, and she gives an account of her patients and the fact that because they're not able to move around because of the fear of COVID, many of them end up becoming less mobile. Their body just can't move because they are so stationary for extended periods of time. So it's physical as well as mental. So I raise it because I think sometimes when we, as government, take positions around the restrictions, even within a fairly risky environment in terms of exposure to the virus, it has to also be factored in the context of some of the other issues around the COVID restrictions. There are the economic issues, but there are some social issues too, and some with health-related implications. And I think, easing some of the restrictions also gives, to some extent, some relief to some of the side effects of COVID. That's the point I'm making. How much of that? That's the balancing act that you have to manage. And you don't always get it right. But these are real issues, and they're very, very difficult decisions. So I say that to say it's not all non-clinical when the government takes decisions around removal of some of the restrictions or easing of some of the restrictions. It may appear risky because of the presence of the virus, but it also addresses some of the public health issues also. All right. Okay. Senator had her hand up first, and then I'm going to come to you, Mrs. MP, Member Holness.
Thank you, Mr.
Everybody I know, yeah.
Thank you, Mr. Chairman. My question is pretty short. Dr. Leiber, thanks for the presentation. In terms of the helpline, you said it was started in what, October 2019. Do we have any data to show what the increase in number and usage after COVID began versus before? So like the number of persons who called and used the facility.
I had a graph. And as I say, it mirrored the spikes that the epidemiology presentation had. This is from October 2019 to April 2021.
Right, my eyes started dark, so I couldn't see some of the numbers well. So I need your help here to help me with this, because I can't see the numbers at the bottom very well. in terms of, do we see where there, so COVID started March 2020, approximately in Jamaica, yeah, when we became aware of it. Have we seen a greater, significantly greater usage?
Yes.
Since the, I can't see it, remember, so you have to help me, remember?
Yes, okay. So October, November, December, January, February, right? You can see a
of
spike.
2020?
Yes. And then it dips, it goes up again over the next 2 months, so it mirrors, then it goes down, and then it around August, July, August, September, you have that other spike. It goes down again, and then we had got a lot of calls in April 2021.
Do we know why that one is so significant?
I think more people know about it. And as I said, and there was also a spike. So I think whenever these spikes occur, people become more distressed and they start calling.
Okay, thank you.
Right. Just to mention, apart from just seeing the increase in the numbers after we've had the peaks. So right after the introduction of COVID, you would have seen that in March, April 2020, our numbers went up. And then, as Doc said, in summer last year, the numbers went up again. And then when we had the second peak in March, it went up again after. But also, she also had another slide that showed that from the NCDA, from the National Council of Drug Abuse, their number of calls also increased, where they had 51 calls in 2019, and they went up to 361 calls in 2020. So clearly persons have been making use of the lines, and she mentioned when she spoke about the suicides, that the number of suicides had actually gone down. And one of the plausible reasons is that many persons have had access to more psychological first aid. There has been more use of the helplines, and so overall we can see that there is a benefit, because in a time when we would have expected the suicides to go up, certainly we see a decrease.
I think that before you come in, Member Holness, I think that's a very important point, because I was recently in a conversation somewhere where there was a perception, maybe because we've had some recent murder-suicide events, tragically, that suicide has gone up during the year of COVID. And the data from the JCF is suggesting otherwise. And clearly, there must be an explanation for that. What the experts are saying is that because of some of the efforts that have been made, because the conditions for loneliness, for depression, for all the mental health issues which may trigger suicidal thoughts, we try to respond with the toll-free line. The training of the reach-out rangers was a big issue. We brought in the Red Cross, guided by PAHO, deployed them in communities, and I would want to think, based on the numbers, in a year that, generally speaking, could be considered depressing, just to use a generic term, it would have had some sort of an impact, and I think that's a positive note. Still have a lot more work to do, so it's not to get complacent, and we just have to build on this. CMO, you had a point?
Right. Just wanted to add the slide, the next two slides down, that showed that there was a use, although less, by males, but there was use by males for the helpline. And we know that a lot of our completed suicides tend to happen in males. And so I think this has been very helpful again.
Question, a follow-up question. Do we have a breakdown of age range in terms of who are the people that are currently using the helpline, and which group is not using it? That is...
Okay, that's kind of ticklish, because let's say if somebody calls you and they're in distress, you don't want to just come and say, well, how old are you? So if it's not appropriate, sometimes you don't really get the age. Sometimes they do tell it. So it's not every call that we're able to get the age. I know from speaking to them, because I was interested in young people, that they cited 10% actually came from youth up to maybe 25. Yeah.
Okay, through the chair. Firstly, I think Jamaicans would want to appreciate whether or not we have any vaccines left at all. I think we should categorically state how much vaccines we still have available, if any. The mono-aging situation today had information being put out there that they had in fact called approximately 150 persons and had vaccines for 150, but over 400 persons turned up and lined up. So I think it would be good for the populace if we have no more vaccines left to just say it. And then following from that, if we are expecting 35,000 doses from Mexico, is that sufficient based on the number of persons who are still yet to get a second dose? For me, I'm equally not very concerned because my observation, particularly in Kingston, and I've been checking the facilities, almost all the persons I checked, the overwhelming majority, everybody got 8 weeks or 9 weeks at a maximum. So I think we are actually comfortable in terms of being at minimum 3 weeks away from anybody needing to be concerned about that 12-week limit. And I think the populace needs to know that so they are comforted. And the fact that the efficacy of the vaccine, having waited for that 12 weeks, is supposed to be better instead of needing to be agitated, because some people are in fact agitated. They need to be reassured. Last but not least is as it relates to tackling mental health. I am very happy to see the volume of effort and work and a helpline actively in place, because Jamaicans have always shied away from even wanting to look at mental health as a concern. Coming out of COVID, and I'm particularly concerned about our children going back to school, I would want to suggest that we make an effort to have these helpline numbers at schools so that children who are still having residual effect, many of them have access to telephones, they can still call in and get support and get help coming out of this period. Not only because of COVID, but other issues that they may have faced in the home or in the community that requires that mental support to take them through the period. Thank you.
It is toll-free.
Yes, you want to respond to the issue of vaccine availability and the concerns raised?
So thank you very much. Thank you very much, Member. First and foremost, I think I must reiterate what the Minister had indicated, or sincere apologies for some of the confusion that obviously have arisen out of how we are proceeding with the vaccination program. So at the end of last weekend, we took 2 days to do a complete inventory analysis of where we were at the time. And by our calculation across the island, we had some 14,000 doses of vaccines in our arsenal. And so strategically, we began to analyze in terms of how do we proceed, given the fact that there was still some uncertainty around when we would get the next set of supply for especially AstraZeneca to provide second dose. And so strategically, we made the determination that we would continue with the application of second dose for persons 50 years and over, and that we would continue to provide only second dose and application of vaccines. Additionally, however, we utilized the database that we had, and we calculated all persons based on their date of first dose that were closest to the 12-week mark. And the database therefore gave us a listing, a line listing of those individuals. Those individuals were then contacted parish by parish, center by center, because the list was then disaggregated by parish and by center. And therefore only a few centers were opened, and the parishes were then calling the individuals directly to alert them to the fact that they are close to their 12-week mark and that we would then invite them to come in during this week to get their second dose. We communicated that, but unfortunately, we have to take account of the fact that the communication might not have been as precise, and therefore persons saw the fact that we were restarting vaccination on Wednesday of this week, and they just looked at their card, realized that the second dose, based on the information in their vaccination card, was now due, and then they went back to their vaccination center. Again, the reality is that we have to apologize for this, but the reality is, as at today's date, we are vaccinating those persons 50 and over, those persons for second dose, and those persons based on the database that we have and information in the database that are closest to their 12-week timeline. I'm sure the CMO and the other clinicians would reiterate the fact that the AstraZeneca vaccine has highest potency closer to the 12-week mark, and therefore we continue to reiterate the point that most persons are now within their 8th to 10th week, and therefore they are not compromised for their second dose. And we believe that the second dose will be administered next week when we are in possession of more vaccines. And so we encourage the population to be patient as we work through these supply chain issues.
Okay, the mental health issue, Dr. Leiber, want to respond to Member Wallace?
Oh, well, I'm agreeing with her, but I also need to share the fact that PSOJ, UNICEF, and Office of the Children's Advocate actually launched a helpline for child and teen helpline, and they felt that, and this was done mainly because they felt that children were so affected by COVID. It's 188 SAFESPO. That is it. It's supposed to be 24/7, and they also have a WhatsApp number for those who may want to text as opposed to actually speak on the phone. So that's another resource that our children and teen, that is available to our children and teen.
Thank you. Okay.
Thank you, Chairman. And thank you for the two presentations. Thank you, Dr. Leiber. I have to say an extra thanks to you. All right, so one or two things that come out, and I am quite happy to see that basically in a nutshell, the use of the non-institution services, so the telepsychiatry, the helplines, but I also am aware through other information that I have reviewed that the use of the community teams was also increased during the pandemic, which is where the service was being taken out to the persons who were more diagnosed with severe mental illnesses and such. So the underlying point is, and I'm just hoping that we don't lose this awareness, is that the community service works, and the community dissemination for the care of our mentally ill is where we need to go. And not that the pandemic is going to go, that these efforts should be stemmed, because the same Capri report relates that only 8.1% of the needs of the children are being met. So we need to work with what has been established and make that even more, especially now that it's been shown to be effective. With respect to and I agree significantly with Member Holness's suggestion with respect to when the children are going back to school. I think that that needs to be very significantly planned, because this report that came out where there were reduced net reports of child abuse, I significantly think is not the real reflection of what the situation is. And when they go back into those spaces, there is going to be great need for the presence of mental health support. And so I think that we need to definitely seek to be proactive with that. Particularly in my own personal experience, there is a significant need amongst teenagers. The teenagers are at normally a developmental stage of identity versus confusion, where they're normally and I say it all the time, that we should be practicing physical distance, not social distancing, because that social deficit is significant for teenagers. I have had a number of them who are going through rough times. So that group probably needs that level of focus. The one other point that I have here is, the psychosocial support technical group that is being established and supported by PAHO. You had mentioned that it is in response to disaster and to prepare for such. Might I suggest that we have a kind of a consistent level of trauma in our society, and we could be seen as having that continuous need. So maybe not look at it through the lens of just in a disaster response. My last comment, Chairman, is around the vaccine itself, and just something that I have come across almost by chance, where I know a participant at the Caribbean American, the Central American Caribbean Amateur Swimming Competition that is happening in Puerto Rico now, and support personnel, adults who got the AstraZeneca, who you are required to have a vaccine to actually go into the stadium to view the competition. The persons who have AstraZeneca coming from Jamaica are being required to do an additional PCR test. Whereas if you had one of the Moderna or the Johnson & Johnson, you are not required to have this PCR test. I am bringing this to the attention with the fact that we would be looking to maybe sending our athletes to Tokyo, and for those international sports events that we may want to consider who and how we disseminate the different types of vaccines based on what the international community is requiring of us. Thank you, Chair.
Thank you very much. Is there a response to the comments made?
Yes, just on the last comment, I would want to say that the focus really has to be on the international acceptance of vaccines, because right now we have several vaccines that have given emergency use listing, and the range of efficacies vary significantly, especially with the newer vaccines that have been added, right? So we do understand that there are limitations, but I think we put ourselves at risk if we try to say, because this one is accepted, then this is the one that you should take. And that will also lead to hesitancy and people delaying, because we have a lot of people right now who are not taking the vaccine because they're waiting. It's not that they don't want to take the vaccine, but they're waiting on a certain vaccine to be available. And our stress really needs to be on the international associations like the PAHO and the WHO, the UNICEF, and all of these other organizations to emphasize the international acceptance of the vaccines. Putting in these rules really put a lot of countries at risk, because we have entire countries that have nothing at all to do with Pfizer or Moderna. So that really has to be where our stress has to be, not to, try to say that it's this one. I really think that we need, in terms of the international supporting authorities as well, we really need to get to them to break that down.
I want to second that point, because it does create some challenges for us. I suspect in the case of Puerto Rico being an extension of the U.S., the AstraZeneca is not a used vaccine in that population. For us, of course, this is our primary one that we use, and as far as we're concerned, it's effective. What we have ensured in terms of the Jamaica context is that we introduce vaccines to our population that goes through the clinical trials and the expert assessment of the multilaterals. And we have come under pressure to ease that rigid examination, but the truth is, from a policy perspective, that has been the way that the government has operated for immunization program, and I think it has helped us to maintain the credibility of our program and indeed our own human development when measured in terms of other jurisdictions or in similar situations. So we have not deviated from that, and what that should say to the country is that our vaccines that we introduce are safe, goes through rigid trials and assessment, and you don't need to worry except for the minor side effects that accompany all vaccines, which we make very clear to you when we administer. The other principle that I think is very important once you cross that hurdle is that that you take the principle of taking a vaccine is to take, as it relates to COVID, is to take the first one you get access to, as long as it meets the standards that I just spoke to previously. Because I do believe that persons have waited on quote-unquote brand name vaccines and may have suffered for that wait because the virus is out there. And so we would certainly want to encourage Jamaicans. But the CMO is correct. The pressure really needs to be applied on these organizing agencies to be guided by the efficacy, the proven clinical trials, and not to restrict based on any particular preference, except that this health and safety standards are met. So thank you for that. I'm going to now yield to Member Guy, who has been waiting patiently and probably has 3 or 4 pages of questions.
Actually, it's 5. Thank you very much, Chairman. First of all, I want to thank the presenters for the excellent presentations. And I'll start with Dr. Leiber's presentation in the main. Just one question, do we have an idea? You've mentioned that teenage pregnancies are up by what percentage or the amounts? Secondly, the impact of COVID on elderly persons is a real one, as has been highlighted here, and it's something that is still going to have some effects going down the road, in that for the most part, they are left on their own. There has been part of the clinical guidelines for the less intermingling, for want of a better word, with the younger population who get out there, and they're in isolation at their home. And Dr. Longmore reinforced the point that it's not social distancing, but physical distancing, which is important. And unfortunately, what we have seen in many instances are persons who socially distance their granny and their grandfather and their uncles and old aunts, and they're in isolation. So some of the effects of this we might see manifested even later on, even when the pandemic hopefully comes to a cessation. But in as much as I want to congratulate the team that is out there in terms of the mental health team, I am looking at your numbers and see that in terms of child and adolescent mental health workload, there is a decrease in the Western Regional Health Authority. Is it that there's lack of reporting? Because it certainly affects the national numbers, where you have a decline of 23.4%. And secondly, I note where, as the first slides indicate, in terms of the parishes where the number of COVID cases have been percentage per population in these respective parishes, that the Northeast Area Health Authority, the community mental health workload was only up by 0.8% compared to over 1 and double digits for the 3 other regions. And St. Anne, granted St. Mary and Portland have less, but St. Anne, in terms of the numbers that we have seen, could and ought to account for a greater increase in the number of visits and the workload of the mental health team. I want this side that the community intervention in mental health issues is what is is very, very important, and the move away from institutionalization is critical, because unless you rehabilitate, for want of a better word, them and reintegrate them back in the community, then we would have lost the fight. And as I move on to the second page now, the helpline in terms of the number of males, and I'm glad you have the slide up there, who have called into the helpline, might not necessarily be a true reflection of the number of males out there who are really suffering, simply because most men want to tough it out and feel that they have some amount of that man not supposed to have this type of problem. So me now go call and seek help. And it is something that part of your team, and I'm sure they have been, but I just want to highlight it here, that it is part of what they need to find out. Granted, you're not going to find out if people don't tell you, but in terms of getting the information and delving deeper, you might be able to get it. So the other part that I want to speak to is the whole stigmatization of COVID. And I know you mentioned that there's a destigmatization program in the ministry. You know, and I just cite one example, which is just one of many, that patients were seen and minister, they were advised that they need to go into hospital because it's more likely COVID that they had, you know, different diagnosis, tentative diagnosis. Me no want what the COVID ward. And many persons fear going into it, and I think it is because of the stigma that is associated with it. And we have a lot more work to do as a nation and as a people for people to recognize that COVID is just another illness, granted one that can have serious consequences. And we need to do a little more work there. I want to jump to the vaccine issue, Chairman, and just a few brief questions. One, the blitz and the confusion that was evident over the weekend in one or two sites, and one today. I am a little concerned that we have a state-of-the-art database that you launched on Monday, but which was in operation before, and that ought to have prevented many of the conflicting texts that went out to the people. And, you know, I hear the apology, and I think the country is willing to accept the apology in terms of what happened, but it probably ought to be a learning curve for us not to go back down that particular route, as subsequent blitz will certainly come. Now, the matter of mixing of vaccine CMO, and this particular one has been, as you know, utilized in a few European countries, and Canada has also proposed that. What is our policy here for those persons who might have gotten AstraZeneca and a second dose in terms of one of the other types, as Minister likes to call them, the brand name vaccines, you know, as the second dose? The matter of the Delta variant being here now, and we know that the Prime Minister made certain announcements yesterday, and we've not reached where we want to go, but the balance has to be maintained. And in light of the fact that we have been told that Delta is the one that is basically ravaging the world now in terms of the number one variant, what provisions are being put in place for a potential spike with the opening of the various sectors in the country? And I think the final one I have on the vaccine is the involvement later on, Minister, as we get down, to involve those private sector doctors who do vaccination as part of their practice, to be involved in the process. And the final one that I have here now is the community testing. we know that most of the testing that is done now is for persons who present to either the clinics, health centers, or the hospital for severe acute respiratory illnesses, and that is when the testing is done. And Minister, you know, interestingly, your numbers could be much better if you did more testing and finding less people. Your positivity rate would go down much faster. But to get a better handle as to what is happening out there, as opposed to those who just present with symptoms and you want to test to find out what is happening, what is the possibility of doing, say, community testing as was done earlier on in the pandemic, and to see if it parallels what we are seeing in the hospital setting, even as a small sample or for a small period, to see if it parallels that, and then we can say, okay, we don't need to do that anymore. These are my questions and comments for now. Thank you.
Thank you, Member, and we appreciate the earlier comments on mental health. I don't think you asked questions as it relates to that. You supported,
just one in terms of teenage.
Except for the region, the western region, was it right? That some of the data seem to reflect some missing elements. You want to comment on that, Dr. Leiber?
Yes. The clinic at Cornwall Regional suffered a big blow with the Cornwall Regional Hospital, whatever. Okay. And it has never recovered. It just, where it was moved to was not suitable, and it just seems to have just declined. And secondly, some of our regions have personnel, practitioners who see children only, and some have none. So the practitioners there see both children and adults. And Western region is one such region. So we have two regions where the practitioners see both adults and children, and we have two regions where we have practitioners who see only children. So those are the two. Oh, no, I don't have, no.
Sorry, teenage pregnancies. No, you don't have that numbers. No. So it's anecdotally we are getting that information.
Yeah. Okay. And it was an article. There was an article in the newspaper 2 Sundays ago. Mrs. Gage Gray was featured, right?
But I'm sure we could get that data, Dr. Leiber, through our hospital surveillance and registration of births and so on, right? Can't we? Or certainly primary health care clinic. So we could follow through on that, Member, because it would be useful to support the conclusion with more data. I'm all for that. Okay, and then the questions now around the testing and the virus itself. CMO, you want to try to address some of those issues, please?
Right. Thank you, Minister. Well, first of all, in terms of a policy for mixing vaccines, we don't have one as yet. We do not have one as yet, okay? But we are observing. We have not seen any real guidance that has come out, coming out of any kind of technical or scientific evidence. So we are watching that to see how it develops. We certainly recognize that there are some countries that are moving ahead with double vaccinations. We also see that there are certain countries that are widening the time for the vaccines, and many persons are responding and reacting to their local situation, and we're probably going to have to do some of that as well. But right now we are viewing what is happening. We are waiting for the technical evidence, seeing what there is, and that will guide any policy. But as of now, we don't have a policy where that is concerned, but we have to be open to that change that may be needed. In terms of our surveillance protocols and the move towards testing in communities, we have to really consider how it is that we test depending on which part of the pandemic we are in. It is always good to have a surveillance protocol and to stick to it, because surveillance is about detecting the trends and not necessarily the absolute numbers. So if it is that you are testing, say for example, your influenza-like illnesses throughout, and those are the only persons that you are testing, then if there is a rise in a particular type of influenza that is picked up, then the trend, you will see that trend going up. Not to say that there aren't more of that in the population, but you're interested in the trend that is happening. So right now, our surveillance protocol has not changed. We tested more before because we had more contacts, and our case investigations led to more people being caught in the testing net. So we went into communities because we had households that were infected. We picked up contacts within the communities and we were testing. Our protocol has not changed. We are still testing contacts. We are still testing the suspected cases. We are still testing the influenza-like illnesses, and we have moved to enhanced respiratory surveillance, where it is that anybody who has respiratory symptoms, even if they don't meet the criteria of flu-like illness, that they would be tested. We're still testing our general hospital admissions. Now, what we have to emphasize to our healthcare workers, which we have been working on, is to ensure that that testing is being done in those groups so that we can, in fact, pick up the trends. Because some of that testing, in particular, the general hospital surveillance, where people come from all over the community into the hospital, gives us an idea what is happening in the communities.
And I ask you to yield, CMO, and I'm glad you mentioned that point, and I think it's something that needs to be publicly said. An experience recently, Minister, where an individual died in St. Mary, and her spouse and children were to be tested. And the report that came back to me is that the doctor at the hospital said the Ministry of Health said, unless me have symptoms, I am not to be tested. And this individual was the spouse of the deceased and the children. Apparently there was some prevailing on the part of the individual, and they finally got tested. But this message, that particular message, ought not to be out there. And I think it is something that you can reinforce at this particular point in time, that this is not what is the protocol.
Yes, member. I think that is important, and we use this opportunity to re-emphasize to persons to stick to the surveillance protocols. However, we do recognize, though, that there is some hesitancy to testing. And where it is that we do the contact tracing in some instances and make the appointments for persons to come in for testing, they are not showing up. We are also finding that when we do the case investigations, people are not giving up their contacts because they're afraid of quarantine and isolation. And so there is the possibility that we are, in fact, getting lower numbers than where we actually are, because if we're sticking to the surveillance protocol, there may be more cases that we would have picked up.
I want to just address, and then the issue of the spike, an anticipated spike, the question that was asked, member. Firstly, from a policy perspective, the government has announced a series of measures which relaxes some of the restrictions. And as I said in my earlier, part of those considerations were not just public health, but economic, social, some addressing the consequences of the restrictions after 14, 15 months. And I think generally speaking, the country understands this, or certainly the majority of the population, that something had to be done because we couldn't remain as restricted without suffering significant fallout. So it really was a balance. Now, where does that leave us in public health? There's a recognition by the policy makers, the executive arm, that based on the recommendations, the expert opinion of the clinicians, that the risks of these measures will increase. The possibility of a surge or a spike could come. I think the Honorable Prime Minister said so very clearly yesterday. And where does that leave us in public health? Well, if there is a knowledge of that, then the issue now becomes how do we manage the process to prepare ourselves for that possibility, prepare the country for that possibility, and there are some very specific things that I think needs to be done. For starters, the public health infrastructure, including personnel, I think are tired, are fatigued, and we should attempt to find a way to provide for them a little bit of rest, at least over the next month or so, even though there's still a lot of work to be done. I don't mean we're shutting down. That's clearly not possible. I think we have to find ways to encourage, to motivate, and give support at all levels of the society, because they've really been at it for a long time, and it's challenging in many ways. Secondly, I think the focus on surveillance has to be a big one, because part of the easing of restriction is also looking at triggers to provide warning signs of the possibility of a surge. And so the surveillance is important, which is why I appreciate the question you ask about testing at the community level. I think we have to ensure that we recognize any trend, even gradual ones, that are suggesting an uptick in positivity rate, in hospitalization, and so on, and signal that very early to our policy, to the policymakers, to the country, and to, if necessary, pull back the levers so that we can minimize any significant fallout. The third is how we prepare our infrastructure. So we have 700 beds. Are there anything else, anything that can be done to prepare our hospital infrastructure should we have this? The other is vaccination, because ultimately how we deliver and how much we deliver is going to not only set the minds of the populace at a better place in terms of their immunity to the virus, and so give them the confidence to move towards normality. But it's going to be important to controlling any potential spread. Now that clearly is not fully in our control. It's a function of access to vaccines. But there is a big logistics tasks. Should we have vaccines to go out into the country and to inoculate a fairly large percentage of the population in a reasonable time? So any plan at mobile units going out into communities, partnerships with the churches, with the elected representatives, with the community leaders, the private sector, whether doctors or nurses. We have to have a plan. And we've done the blitz, so we've had some experience. But we have to refine that and be ready for that. So there's still a lot of work for us to be done, and we will have to recalibrate and focus to manage any potential spread and minimize that spread either through prevention, the vaccine program, protocols, or through management for cure, for getting people well again if they have the virus.
Chairman, could I ask that in this recalibration, I ask a question about the private doctors, that be part of the consideration, as we have asked before. I said it was a final question, but there's one final one. And it's not a question, but it's a concern. And the vaccines we got under the African Medical Support Platform had short expiry dates, right? I mean, we didn't have a challenge from our side in terms of it being administered because we felt it was still safe, as did the entire team from the ministry. I'm just echoing a concern as to whether this 35,000 doses we're getting from Mexico was that any of those that they had gotten from the US in March, and whether the expiry date is closer to a point in time. And we need to know that so that the ministry can plan accordingly to have these utilized before it is near the expiry date, if it is.
Well, I'll leave the CMO to respond to that, but what I would say is that given the need for second doses, I think the ministry is fairly ready and prepared to administer that 35,000 within a relatively short period of time. You've seen the desire for those who have had their first dose. So, and I think we have the capacity to do it, having delivered 83,000 in 4 days. So I wouldn't be worried about that, but CMO, you may want to come in further if necessary.
Yes, just to say that we have received documentation, so we know that it is vaccine that expires, I believe it's September or October, but there's a few months on it, and we do intend to use it up in a week or 2 weeks.
All right, final question. I think Member Holness had her hand up. You still want to ask that question, Member Holness? And then
Sort of a question, comment. I'm not sure if the observation is correct, but I am sensing that we actually have far fewer cases of influenza. I just don't see right across the board observing the population that I'm finding people having flu in the way we used to. I would want to hope, and just observing different countries with different cultures and observing where we have really significant case of COVID, you almost see a cultural connection. I find Jamaicans who bathe every day almost, and because of COVID, we are going the extra mile to sanitize, wash our hands. I have observed, and I don't know if we have any data, that we are actually healthier and yes, respiratory illnesses, incidence of flu, so, and exercising a little bit more. So I am really hoping that coming out of all of this, a part of the Ministry of Health program is to continue to remind us to remain a clean society, which is a healthier society, which makes for increased productivity and ultimately a better place for us as Jamaicans.
Well, we do have some information because certainly we know that over the years we have been affected by the Sahara dust. And in 2019, I recall the increase in the number of visits to the emergency departments that we had. In 2020, when I checked, not one emergency department, even though the dust was thicker than it was the previous year, had recorded that they had increased in number of visits. And then this year, we're in that period of time now, and we're not seeing the increase in visits. We also saw recently Dr. Carleen Grant, head of the pediatric department at Cornwall Regional Hospital, had a letter, an editorial in the paper, an article in the paper, where she had said it was infectious diseases on a whole, including gastroenteritis. You know, they had seen a significant decrease in the number of children that were presenting to hospital because of infectious diseases on a whole. So certainly, you know, it does indicate, and we will have to look at our surveillance data. I don't know if, Dr. Wellington, do you have any comment? Right, so Dr. Wellington is saying, because we do track in terms of our syndromic surveillance, fever and respiratory symptoms, gastroenteritis, etc. And so Dr. Wellington is now indicating that we are seeing less of these cases.
I think the general infection prevention and control measures around COVID globally have resulted in significant reduction in those kind of infectious conditions. And if we were to identify a good thing then out of COVID, it is that other normal cyclical ailments that are linked to infectious or infections have reduced. And so there are lessons to be learned from that. And I was speaking at a function this morning where I outlined, was trying to advance a perspective on the future around infection prevention and control as a non-clinician, and suggesting that a review of those measures are going to be necessary, learning from the experiences that we have had in the management of COVID. And I believe we have the team here that are seized with that need, but I also think it's a global conversation that will take place. So you will see changes that will be beneficial to mankind, hopefully. All right, the final, and then we're going to close because I think we have met the 2-hour mark, even with the wait that we had earlier.
Thank you, Chairman. I just wanted to bring home the point that as we see where the extension of curfew hours, there's some efforts to try to slowly reopen, get back to a new norm. I just saw where 5,000 spectators will be permitted to the national trials at the National Stadium, and the capacity is 35,000. That we not get too complacent, that we remain very, very protocol-oriented. My forever message of immune boosting, there is absolutely no question that it works, and I think especially now as we go into the summer months and hurricane season comes, and there could be that resurgence of some of the infectious agents, that we emphasize the need to still ensure protocols, to still be very aware of our environment and still practice the safety measures that has brought us to the point where we're able to, because we don't want to backslide. Thank you, Chairman.
Thank you very much. I don't think there is a need for any comment on that. So I want to thank again our presenters and the team from the Ministry of Health, and thank colleagues for their questions. So we're going to move to item 8 quickly. Any other business before we set the date for the next meeting? Any other matter that you want to raise, members? Anything else? No? Going once, twice? CMO?
Yeah, just wanted to comment on a question that Dr. Guy had asked about in terms of preparation, and just to mention our continuing of the building of capacity. We have several agreements with our partners internationally, and countries like China, South Korea, Japan, Saudi Arabia, through the Ministry of Foreign Affairs and Foreign Trade. We have been getting assistance with equipment, preparing, getting more high-flow nasal oxygen systems, oxygen concentrators. We have been focusing on getting those, more monitoring equipment, more ventilators. So we do continue to prepare to build capacity in the event that we do have another surge.
Thank you very much. Okay, any other business? No? All right. So we are here trying to find a date for the next meeting, and we're proposing with your... I know you're going into the summer months, and you're now free to party, so you're looking all the time that you... Oh yeah, there's a work. I hear you. No, I think it's important to do a July. So we're proposing Tuesday the 20th of July at 12 noon. Tuesday, yeah. 12. After PAC, just before. Yeah? Huh? Kind of, yes. No, which other, what other date you have? You have the 27th.
The 27th at the same time.
No, yeah. Can we try and do that Tuesday? I mean, which other day? Apparently the diary is full. The 20th. The 20th. Yes. If we can. Right.
If not, Chairman, we'll just work with September.
Yeah, I don't want to. I think it's important to do something in July.
Also speak with the PAAC chairman. We are scheduled for the
Right. So I think it's important to do something in July, given all that is happening. So can I get an agreement from members that we'll try with the intervention of member wholeness, and then we'll do some follow-up for the 20th of July. Is that okay? Yeah, 11:30. Okay? 20th, yeah. Right? Okay? All right. Thank you very much. Yes.
One final matter. I think the committee needs to decide so that we can get to the Parliament, as we had discussed earlier on, the possibility of virtual or quasi-virtual meetings. So the resolution needs to be moved, but I think the committee needs to make that recommendation.
We had done it when we were significantly restricted. I'm just wondering if it sends a particular signal, given that we're all double vaccinated, I believe, and we're moving more to opening up, and the committee is moving towards.
Chairman, it doesn't mean that we have to utilize it, but at least that it's there just in case
option.
we want to.
Well, I mean, if members are so inclined, although I would say the more we move towards opening up is the more I think we should meet here, for more reasons than one. But
the more we move towards opening, Chairman, we should still create a sense that the world and life is different, and we are going to need, in terms of efficiency and productivity in the future, to start looking at the option of virtual arrangements. It is very efficient.
I agree,
yes.
But you know, there are some things I would like to eyeball my colleagues from a close distance at these meetings. So maybe what we should do, we can move the motion to make it an option. Okay? Can we do that? All right. Motion for adjournment. So move member Guy, seconded member Wholeness. Thank you very much. Thanks to the health team, and thanks to members for attending. Thank you. Thank you very much.